Cool. So if we have those on the call, or for some of you who might have been at the Lions conference earlier this year, you've heard that kind of the big take-home message from my presentation at the Lions was that for chiropractic to be more successful, we need more successful chiropractors. So again, kind of just reiterating what I've said already is this presentation is designed to help you get some stretch marks, as Rob said, to try and challenge yourself in clinic and in practice, to see if there are any things that you can do to improve your clinical outcomes, because that's kind of all that we're really interested in, really, isn't it? You know, we want to do the best for our clients as often as we can. So we're going to spend the next couple of minutes just talking about some of the hidden causes of numbness and tingling. And kicking things off, if we look at numbness and tingling, as kind of an umbrella term, we know that both of those symptoms can be caused by a number of underlying benign or malignant pathologies. As chiropractors, it's our clinical responsibility to rule out the malignant stuff or refer out for it to have it investigated. And once we've done that, we then need to continue down the path of evaluating numbness and tingling. However, that's a little bit easier said than done, given the subjective nature of numbness and tingling, and just how broad those terms can really sometimes be. You know, what is numb to Connor might not be numb to Rob, and, you know, if I'm describing something as being tingling, that might be burning someone else. So evaluating sensory complaints is quite a clinical challenge in itself, but one that we need to become proficient at, because it is something that we see a lot of, and it is tied to a lot of conditions that we're going to have a look at next. So when we look at some common causes of numbness and tingling, and again, this list is not exhaustive, but
Mike, your screen hasn't changed.
What? Again?
We're stuck on the first thing, so it might be better to reload it. Sorry.
Sharing is paused. I don't know what's going on. There we go.
That's it. You got it. You're good to go.
Oh, sorry about that, guys, but yeah, a bit of a technophobe over on this end of the call. So just going back to kind of looking at causes of numbness and tingling. And again, this list isn't exhaustive, but it's some of the ones that I thought we would likely come across in clinic. And now you'll notice that if you have a brief look at the slide, that there are a lot of mechanical causes behind numbness and tingling, you know, so things like discs or radiculopathies, sciatica, spinal cord injuries, for example. But you'll also notice that there are a couple of chemical and or metabolic causes behind numbness and tingling. So things like hypocalcemia or low vitamin B or hypothyroidism. So what this means is that when someone presents to your clinical practice with the complaint of numbness and tingling, we need to keep our clinical hats on. And what I mean by that is we need to be aware of, as Rob's kind of alluded to as well, that there aren't only neuromechanical causes behind certain symptoms, but neurochemical as well that we need to take into consideration. Keeping that in mind, if we can put that all together in our kind of biopsychosocial approach to healthcare, we stand a much better chance of getting things right more often than not. Because let's be honest, when I mention numbness and tingling, most of us will likely jump to mechanical causes, because let's be honest, as chiropractors, that is something that we see quite a lot of. And, you know, to borrow an old adage, when you hear hooves, think horses, not zebras, or common things occur commonly, to put it another way. So again, numbness and tingling might kind of set off for you guys things like disc issues, piriformis syndrome, brachial plexopathies, carpal tunnel, etc., etc. However, we oftentimes fail to remember that there are other causes to numbness and tingling that aren't mechanical or neuromechanical in nature. And if we can keep that in mind, and if we can keep that approach to our clients in mind, then what it means is that we're likely going to see our success rates go up, because we don't want to be like this guy here over on the left. If anyone's a Ron Burgundy or Anchorman fan, they'll get the reference. But we don't want to just get things right some of the time. You know, we want to get things right as close to 100% of the time as possible. So what I've done is I've just put together a little case study, which I think will highlight kind of the point that I'm trying to get across to everyone here today. And we'll kind of start. This is a 43-year-old female comes into the clinic with intermittent tingling and numbness in the left hand for the past 6 months. Symptoms have a fairly rapid onset whenever they come on, so it's not a constant pain. It kind of comes and goes in bouts. She attributes the pain to her poor sleeping posture, as well as the fact that she works as a software engineer. So she's behind a desk for 10 to 12 hours a day in a horrible posture. She's seen some Chinese medicinists for this in the past, which has kind of given her positive outcomes. And she gets a massage either at home or from a massage therapist, which gives her some relief as well. And then in her exam, she mentioned some mild neck pain and trapezius muscle spasm or tenderness too. So this is probably someone that we've all seen in clinic. You know, the likelihood of someone matching this description coming into your practice is probably quite high. And most of us, myself included, would probably assume that this lady had some form of neuromechanical cause to her pins and needles or numbness and tingling, and we would start a course of care. Now, within that course of care, you might do some adjusting, you might do some activator work or acupuncture. You might give this lady a Diuretics to take home if you've done cervical spine x-rays and your CBP working. You might give her some controlled articular rotations or like a rehab program. And she might get better, significantly so. She might improve slightly and then kind of hit a plateau, or show no improvement whatsoever. But let's bear in mind that if this client came into your office, you adjusted her regularly, she stuck to her care plan, she was following all of your advice, she improved but didn't quite get all the way. What are some things that we can then consider that may be going on in the background that could likely explain her numbness and tingling? So keeping things in theme with Rob's discussion today, I thought that we would unpack some of the nutritional deficiencies which can cause numbness and tingling. So some of the common ones, and I think these are the ones that we're all likely to see, and I'll explain why in a couple of slides, are kind of these big 8 ones that we kind of have on the screen at the moment, and that is potassium, calcium, magnesium, copper, B6, B1, B12, and vitamin E as well. So purely because of time, today we're not going to unpack all of those, but I did think that we would go through 3 of them really nicely and quickly, because again, these are all things that I think you guys can take away at the end of this presentation and into practice with you later on today, if you are, like me, lucky enough to be back in clinic helping the people that need it at the moment. So if we look at the first nutritional deficiency, potassium. Okay, so the big thing to remember with a potassium deficiency is it's not likely going to be due to a poor dietary intake. Okay, the prevalence of mild hypokalemia is approximately 14% worldwide, so fairly high if you compare it to kind of other nutritional deficiencies. It is the most common electrolyte imbalance in hospital-based patients, accounting for about 20% of those. And its most common cause is excessive potassium loss due to prescription medications. So here the big culprit are diuretics. So your thiazide or your loop diuretics, so things that, like for water pills, for lack of a better word, which loads of clients are on because it's often the first port of call that GPs will work towards when trying to bring down hypertension. And again, if you think about the number of clients that you see in clinic that are on blood pressure medications, this slowly starts to become something that you need to keep thinking about. Moving next on to magnesium deficiency. So magnesium deficiencies have a slightly lower prevalence than calcium, between 2.5% to 15%. Symptoms don't usually present until levels are very low. Okay, so when we do catch this, it often means that we need to take quite a rapid approach to getting those magnesium stores back up again. Often goes hand in hand with other metabolic abnormalities, so something like hyperkalemia often will be found alongside hypomagnesemia. Again, diuretic medications are a big culprit, as are proton pump inhibitors. So again, medications for like heartburn, for example, and again, that in itself is a huge kind of clinical symptom that we see in practice a lot, and we know a lot of the population are on PPIs. And we also know that magnesium deficiency has a big tie to diabetes or insulin resistance, which again, as Rob kind of said, Boris is, kind of understanding now that the health of our nation is not necessarily where it should be or where we want it to be. So knowing all of these things can start to give you pieces of a puzzle that you might have been missing in the past for your clients that have numbness and tingling. The last one we'll look at is perhaps one of the more common ones, vitamin B12. It is a deficiency found in about 6% of the people under the age of 60, and in about 20% of those over 60. Some studies suggest that this number can be as high as 40%. And again, if you kind of think about the clientele that we see in clinic, I know personally I see quite a lot of 60-year-olds or thereabouts. A lot of them are diabetic, a lot of them are on hypertensive medication, and quite often, you know, may or may not mention that they've got a bit of numbness and tingling. So with that going on now, you can start to see how this information becomes relevant when assessing your best case or best course of action in managing that client. Big problems with vitamin D is that testing it is pretty poor. There is no kind of international standardized range that we have, so we don't have clear markers for thresholds. There's a really large kind of gray zone right in the middle. So even NHS guidelines, for example, won't likely address that too much. Vegan diets are a huge source of vitamin B12 deficiency, because we know vitamin B12 is synthesized in animal products, so we need to ingest it to get it. We can synthesize a small amount of it in the gut, but it's inert or inactive, so we don't absorb it. Big medications that will hamper B12 are things like the contraceptive pill, metformin, so again, diuretics, proton pump inhibitors, colchicine, so medications for gout, and then ibuprofen. So just looking at those there, again, if you think about the number of people that we see in clinic that are on one or more of those medications, and we can appreciate the leaching effect of B12 that those have in the human body, and that person has numbness and tingling, this should be getting your spidey senses tingling, pardon the pun, and switching you on to understanding how you can better serve that client in clinic. Pernicious anemia is often something that we kind of confuse with a vitamin B12 deficiency. And yes, you know, obviously pernicious anemia is an autoimmune disorder where we lack intrinsic factor in the gut, so we can't absorb B12. And another one where we see a significant B12 deficiency is in gastric bypass surgery. So anyone who's had gastric bypass surgery should absolutely have a flag next to them for looking at their B12 levels. So when we consider numbness and tingling, we need to be aware of the fact that there are not just mechanical causes behind it, because it is something that we as chiropractors are known to help with. It is also something that we as chiropractors market towards quite heavily, in fact. So this is just a quick slide from a Google that I did. You know, you can see here chiropractic numbness and tingling. We get just over 800,000 hits in less than a second. So if this is something that we're proclaiming to be able to help with, and it's something that we're telling the marketplace that we do help with, then we better bloody be sure that we know what it is, what causes it, and why it might be persistent if our clients aren't responding the way that we expect them to in the suspicion of a neuromechanical cause of their numbness and tingling. As another kind of line of ours has said in the past, Simon Billings, chiropractors have two things in common. We have clients who get better, and we have clients who don't. Now, I'm not saying that every single client who comes in to see you who has numbness and tingling will have a nutritional deficiency. But what if that one that does come into your office does? We need to be prepared to understand how to manage that patient moving forwards. If we look at a quote from the chairman of the Royal College of Physicians, he says, all doctors should be able to diagnose and treat nutritional deficiencies. And I think this really is quite true for chiropractors as well. Maybe not necessarily treat them if that's not your gambit and it's not your interest, but we need to know at least how to identify them so that we can refer out if we feel that we need to. But if we miss this, we are leaving a lot of meat on the bone, and we're leaving a lot of clinical outcomes and benefit for our clients on the table as well. So it really is something that's super important for us as a profession to kind of know about moving forward, especially as we're suspecting people to be more health conscious post kind of coronavirus as well. So if we consider a hypothetical case study, so this is, for example, a man that walks into your practice, we'll call him Paul here for this example, has his annual wellness check at work. He's told his blood glucose is a little bit high and that he needs to go and see his GP. So goes to his GP, who figures out that Paul has a family history of diabetes and prescribes metformin. What we know from the slides previously is metformin drugs will deplete the body's natural B12 and folic acid levels. But Paul doesn't really know that. He's not really been told. So he faithfully takes his metformin for 3 years, gets his blood sugar under control, but then starts to present back to his GP with a bit of numbness and tingling in his feet, and he feels a little bit irritable and a little bit tired. His GP, Paul, you've developed diabetic neuropathy. Take this gabapentin and this Zoloft. That should help with the numbness and tingling and some of the irritable feelings. Now, what if Paul's symptoms here were due to nutrient depletion? What if we had intercepted him prior to getting given the gabapentin and the Zoloft, and we as chiropractors who take a broader view to their health understood that long-term metformin use is going to naturally deplete this man's B12 levels. So how can we help this guy? What can we do? And I think that really is kind of the critical question from today is, if these clients are coming into us, anyone presents to you with numbness and tingling, and they're not responding to your course of care, or you suspect that they may have a nutritional deficiency, you either need to refer out to have it addressed or assessed, or you need to take charge of that yourself. Because I think we owe it to our clients, and we certainly owe it to the profession as well. So to finish off, what we're going to focus on is what can we do? So, pardon me, how can we move the needle once this conversation is over? And I think there's kind of 3 key things that we really need to remember. Always wear your clinical hat and understand the interaction between the neuromechanical and the neurochemical of common things that you might see in clinic. Understand why someone might be deficient in a certain vitamin or mineral, whether that's from medication or they're losing it or it's not in their diets, and then test to see if that is the case. So a couple of really helpful resources that I've used in clinic and that I would highly recommend to anyone who's on the call with us today is a website called b12d.org. It's a charity-run website by a quite famous NHS doctor, Dr. Chandy. And on this website, you can see they've got this downloadable PDF. It's free for you to use as much as you want. It's a 1-minute health check that you can get your clients to fill out, or you can send to your clients to fill out before their consultation to assess and understand if they may be B12 deficient. On the flip side of that chart, it also gives you a roadmap in terms of how to best go about managing that client if they do turn out to be B12 deficient or not. So really easy to use resource that, again, amazingly is free of charge. So go and check it out. On that same website, so b12d.org, they have that same form that you've just seen, but on an online calculated version. So it takes up all the math, which is for someone like myself, a fantastic thing. So again, you just send this link to your clients, or you can do it with them in the office on an iPad. It's pretty easy. They fill in their numbers, you get an automatic reading, and it gives you an automatic pathway as well. So really no excuse to not know how to move forwards with B12. This is just another quick website that I use. I've just done a little video kind of recommendation here for you guys. A website called Mytivin. A lot of you may have heard about this, but essentially this is a website where you can go in, you can plug in certain medications like I'm doing here, so metformin, which we're giving to, let's say, Paul, our hypothetical case study, and let's say he's on omeprazole at the same time. So you bang in those medications, you hit calculate, and what it's going to tell you is what that patient might be deficient in from a nutrient standpoint based off of what medications they're taking. You can also see that there's references to all the studies that people use in this, so you know that it's all research-backed and evidence-based. So that's mytivin.com. It's a really fantastic website, and again, free for you to go and use. And what you'll also see is that on the Mytivin website, they've got things like case studies. So I think this one fits in quite nicely with what we've spoken about today. A young lady on oral contraceptives develops these number of symptoms which may have been due to nutrient deficiencies, but when missed or unheard by her GP, purely because they never really thought to ask those questions. So that is kind of it from me today. I know we went through that pretty quickly, but I do hope that has given everyone some stretch marks, as Rob said, which I think is a great term, and has kind of encouraged you to start thinking about some of the lesser known or the hidden causes behind numbness and tingling that your clients might present with, or in clients who don't respond to your care modalities that you're using at the moment. If anyone wants references for any of that, please let me know. I'd be more than happy to send them across to you. I'm also more than happy to share this slideshow with anyone who is interested in it as well. Other than that, yeah, I hope you guys got something out of that.